Good afternoon. Thank you to the moderators and sages for the invitation to present. I have no disclosures for this presentation. So when I think of abdominal wall reconstruction, patients who come in with imaging like this is really what I'm thinking about. So the patient on the left is a former kidney transplant patient who came in with an incisional hernia and associated abdominal wall loss of domain. And the patient on the right has an end colostomy from fecal incontinence who came in with intermittent obstruction and pouching issues. So when I'm talking to them about abdominal wall reconstruction, really my goal is a long-term durable hernia repair. In addition to preoperative patient optimization, there's several intraoperative decisions that are made, including the mesh type selection that helps contribute to your durability of your hernia repair. For the next 15 minutes or so, I'm going to talk about the goals of abdominal wall reconstruction, the proposed benefits of biologic mesh, current data on short and long-term outcomes of abdominal wall reconstruction with biologic mesh, as well as patient-specific considerations in clinical scenarios where the use of biologic mesh may be a little bit more appropriate for abdominal wall reconstruction. So what is the goal of abdominal wall reconstruction? Really, you want to perform a hernia repair that recreates the structure and function of the abdominal wall over the long term. And simply put, you want to perform a hernia repair that has a low associated rate of hernia recurrence. Some of the components or tenets of abdominal wall reconstruction include selecting the correct patient and optimizing their modifiable risk factors, selecting the correct procedure for that patient, paying special attention to the skin and subcutaneous tissue, and carefully managing the patient postoperatively. Underneath selecting the correct procedure includes additional considerations, which are tension-free primary repair of good fascia to good fascia, mesh reinforcement of the fascial repair, proper mesh placement and fixation, and finally your mesh type selection, which is really what we're going to focus on. So if you're anything like me, I tend to assimilate mesh type selection a little bit to alphabet soup. What mesh properties matter, what patient factors matter, what's happening in the operating room that can really guide my decision in terms of the mesh type I'm going to use for my abdominal wall reconstruction. So the purpose of mesh, generally speaking, is to replace or augment native tissue. And the proposed purpose of biologic mesh is to replace or augment native tissue and to resist infection, which should therefore facilitate incorporation in contaminated fields. But does that actually happen? What is our data showing us in terms of how biologic mesh acts in vivo? So again, like I stated, the proposed benefit of biologic mesh is how it behaves in contaminated ventral hernias. Unfortunately, this is going to be a little bit of a journal club. So first I'm going to talk about contaminated ventral hernia repairs, and then I'm going to talk about all comers. So the first study I want to talk about is the RICH study, which was published in 2012. RICH stands for Repair of an Infected or Contaminated Hernia. This was a multi-institutional prospective study. It included 80 patients. The average hernia size was 236 square centimeters. 81% of patients had primary fascial closure, and stratus mesh was placed either in the retrorectus or intraperitoneal plane, and there was 2-year follow-up data available. And what they found is that the rate of hernia recurrence was 28% at 2 years. The next study was performed in 2016 by Dr. Nowitzki's group. This was a multi-institutional prospective study. It included 126 patients. The average hernia size in the biologic group was 343 square centimeters, and the average hernia size in the synthetic group was 356 square centimeters. The majority of the repairs were retromuscular, and the mesh was placed in a sublay position. The biologic group underwent hernia repair with a porcine xenograft, and the synthetic group underwent repair with a macroporous polypropylene mesh. The average follow-up was 20 months. And what they found is that the rate of hernia recurrence in the biologic group was 26% compared to 9% in the synthetic arm. Next is a systematic review and meta-analysis that was also published in 2016. It included 21 studies with over 6,000 patients. Again, it included only CDC wound class 2 or 3 hernia repairs. And the study was kind of for all-comer hernia repair types, mesh types, as well as mesh location. They did divide the rate of hernia recurrence into CDC wound class 2 and wound class 3. And in order to be included in the analysis for the hernia recurrence, you had to have at least 1 year follow-up in the study, and at least 75% of those patients in that study had to have primary fascial closure. So in the Biologic mesh group for CDC wound class 2, there were 5 papers with a follow-up that ranged between 15 and 43 months, and they found that the rate of hernia recurrence was 9%. In the synthetic mesh arm, there were 4 papers that met this inclusion criteria, and the follow-up ranged from 13 to 20 months, and they found that the rate of hernia recurrence was also 9%. But interestingly, as you move up into CDC wound class 3, there's 4 papers for the biologic group with a follow-up that ranged between 12 and 24 months, and the rate of hernia recurrence increased from 9% to 30%. Unfortunately, there was only 1 study that detailed the outcomes using synthetic mesh. They had an average follow-up of 10.5 months and a recurrence rate of 7%. And finally, and last but not least, is this new study that was published by Dr. Rosen's group in JAMA Surgery. This was a randomized controlled trial performed between 2012 and 2019. It had 251 patients that had completed their 2-year follow-up. The median hernia width was 14 centimeters. The mesh used was either stratus or barred soft mesh into the retromuscular space. And they found that there was a 20.5% rate of hernia recurrence in the biologic group at 2 years, compared to 5.6% in the synthetic arm. And interestingly, they found that there was a 14.9% absolute risk reduction in the risk of developing a recurrent hernia if you underwent your hernia repair with synthetic mesh. Moving on to all-comer hernias, the Lapsus trial was a randomized controlled trial. It was performed in between 2005 to 2009. There were 17 sites in Europe participating. It was supported by the European Hernia Society. The inclusion criteria was a hernia defect between 4 and 10 centimeters. There were actually 4 different groups for this, so 2 in the laparoscopic arm, 2 in the open arm. In the laparoscopic group, patients underwent a bridged repair, regardless of if the repair was performed with biologic or synthetic. The biologic used was either Surgisys or Gore dual mesh, and the synthetic mesh used was a barred composite mesh in the laparoscopic group. In the open group, all of these patients underwent primary fascial closure. The biologic used was Surgisys, and the synthetic used was barred polypropylene mesh. Unfortunately, this study and trial was terminated early, and the authors concluded that based on the as-treated population of 257 patients, whose surgical approach and type of mesh can be verified at this time, the exploratory analysis with a median follow-up of 1 year showed that the implantation of Surgisys resulted in a higher rate of early hernia recurrence in each of the study arms. 19% versus 5% after laparoscopic repair, and 11% versus 3% after open repair. A recent study that was published in 2021 is a single institution study. It was performed between 2009 to 2015. It included 68 patients. The average size of the hernia was 325 square centimeters. They used permacol mesh, and the location of the mesh placement and the ability to achieve fascial closure varied a little bit amongst patients. And what they found is that the cumulative recurrence rate was 61.8%. The average time from repair to recurrence was 18 months. The likelihood of recurrence was highest for those patients who underwent an intraperitoneal bridge and lowest for those patients who underwent primary fascial closure. This is a little bit earlier on kind of in our experience with biologic mesh, but I think it's important because it's a systematic review. It included 60 studies with over 1,000 patients. They looked at all different types of biologic mesh. And what they found was the cumulative recurrence rate was 15.2%, and it was higher for cross-linked biologic mesh. And finally, this was recently published in Hernia in 2018. This was an expert panel based out of Europe known as the Biomesh Study Group. They reviewed the data and evidence for all potential ventral hernia repairs, as well as the data and evidence for all potential wound classes. And they also looked at the preemptive biologic use. So for example, at the time of stoma creation or stoma closure, or the closure of a midline laparotomy. And their ultimate conclusion, based on all available data, was that the routine use of biologic and biosynthetic meshes cannot be recommended. So what does the data tell us? The purported benefits of biologic mesh for abdominal wall reconstruction are not supported by our currently available data. Therefore, the routine use of biologic mesh for abdominal wall reconstruction cannot currently be recommended. However, I will say there's probably some exceptions to our data conclusions. So, like I stated earlier, the ultimate goal of abdominal wall reconstruction is a long-term durable hernia repair. There are some considerations in clinical scenarios where you're likely not trying to achieve that goal. So, for example, a temporizing situation. Your high-PEC patients, they've been in the operating room for 12 hours, they've undergone resection of a significant portion of their abdominal wall, or your trauma patient who you're just trying to get abdominal wall closure for to temporize them and improve their hemodynamics. Again, like we talked about in some of the previous talks, patients who don't desire a permanent prosthesis, that's something that you have to talk to them about, and whether or not you're gonna use a biologic or a bioabsorbable mesh. And then something that I wanted to touch on briefly is bullet point number 3. As the cost of biologic mesh decreases, we may see an increase in the benefit or use of biologic mesh. So this is a study that was performed by Dr. Paulos' group, and he was looking at the cost-utility analysis of biologic and biosynthetic mesh. So he looked at the current costs of ventral hernia repairs with synthetic mesh, biosynthetic, and biologic. And what he found is that the cost for a ventral hernia repair with synthetic mesh is currently around $15,000, and the cost for a ventral hernia repair with biologic mesh is currently $31,000, so about double the cost of a ventral hernia repair with synthetic mesh. And then he really performed these risk-adjusted analyses looking at what point may we see potential benefit of using biologic mesh or a higher upfront cost for biologic mesh. This is very confusing, and my brain does not work like his because he has an MPH. But so if you look in this chart, on the x-axis is looking at the probability of long-term synthetic mesh complications, and on the y-axis you're looking at the cost of biologic mesh. The yellow area is your synthetic mesh, the red is your biosynthetic, and the blue is your biologic area. So again, we've kind of touched on this a little bit as well. We have great data at 1 and 2 years follow-up, but what's happening to these patients at 5 and 10 years? Are there additional complications with synthetic mesh? And so he was really showing that the potential kind of area for the use of biologic is if the overall cost of using the biologic mesh decreases, and with long-term follow-up, we're seeing these increased complications with the use of synthetic mesh. So in conclusion, based on currently available data, biologic mesh does not have a role in abdominal wall reconstruction. It is possible that biologic mesh may have a role in ventral hernia repair operations when a long-term durable repair is not the primary goal. And again, as the cost of biologic mesh decreases and the potential complications with synthetic mesh increases, you may see a potential expansion in the use of biologic mesh for abdominal wall reconstruction.